But I wanted to thank everyone for joining us this morning and welcome you to our ABNY Talks with Mary Bassett, the New York State Health Commissioner. You know, it's really important that we have these conversations, and we're really proud of our ABNY Talks series because it's a really important part of our programming here at ABNY. You know, this series really allows us to bring timely and relevant topics to our membership, and more importantly, to the general public for meaningful discussions about the things that impact our lives every day. And ABNY Talks really is a series that is free of charge, and it's meant to be educational and participatory. And it's really a great way to pass on information that will keep our city moving forward and really to keep our city strong. And in this moment, when we are navigating the strategies and the practices to deal with the current phase of COVID, we know how important it is to be up to date on the newest guidance from our public health professionals. And that's why we are really excited to bring you today's ABNY Talks. So with that, I'd like to ask Stephen Rubenstein, ABNY's chairman, to introduce today's speaker. Stephen, Zoom over to you.
Thank you, Melba, as always. Morning, everybody. Thanks a lot for joining us. As Melvin mentioned, we are lucky to have our state health commissioner, Dr. Mary Bassett, with us this morning. We are excited to hear from her, and given the times we're in, we have a lot of questions for her. I know many people on this Zoom feel we are over and done with this pandemic. We are glad that our masks are coming off, but we all have a second feeling, which is this pandemic done with us? And if you're on the Zoom, if you're in our community, you tend to pay a fair amount of attention to what's happening in New York as well as trends around the world. To understand these facts, understand where we are now, what it really means for New York, we're lucky to turn today to Dr. Bassett. This is Dr. Bassett's first time with us in her current role with the state. Many of us know her and have felt her calm and controlled wisdom and voice during the 2014 Ebola scare when she served as New York City's health commissioner, a position she held for 4.5 years. We were lucky to have her on the front lines then, and we're lucky to have her on the front lines now. Dr. Bassett has an extensive background in infectious diseases, including nearly 20 years spent confronting the AIDS epidemic in Africa, with over 15 of those years spent living in Zimbabwe, where she served on the medical faculty of the University of Zimbabwe. She is one of the world's most sought after experts on the intersection of equity and public health, something vital to our pandemic response here in the city and the state. I want to extend a big thank you to Dr. Bassett, as well as her New York City counterparts. Since the early days of this pandemic, city and state officials have been really careful and exemplary in communicating with New York as a whole, as well as working with ABNY, our business and civic community, throughout, something that has really been vital as we all coped. We're grateful for the partnership we have with her, as well as with Governor Hochul, and look forward to a healthy future together. And I should say, because as much as the pandemic dominates so much of our lives, our behavior, and our conversations at this time, we also know it is just one of the issues facing us as we to have a healthy and well-being of our city and state. So welcome to ABNY, Commissioner Bassett. Thank you for being here, and the Zoom is yours.
Thank you. Thank you very much. It's a real pleasure to join you this morning. And thank you, Melva, and thank you, Steve, for a really lovely introduction. I'm proud to serve as the New York State Health Commissioner. So I'm going to be talking about where we stand with COVID and talk a little bit about how we're thinking about how we go forward. And I'm going to be showing you quite a lot of data to do that. And I'll look forward also at the end to having your questions. I'm going to go over the sort of waves of COVID as they've blown across the state and the nation, what we're seeing now, and end with what we've learned over the course of this response. And I've only been health commissioner for part of this response. Here you see on this slide the waves of COVID that have been experienced in New York State. This first one was the one that was the most devastating. New York State, and in particular New York City, were the gateway for COVID for the nation. And the toll that COVID took in wave one, I think you can see my pointer here, still places New York State in the top 10 of deaths in the nation. because we had so few tools, and this was a once in a century event. But it's been followed by other waves, and you can see that there's a seasonal pattern. So the winter surge was followed by an uptick related to a new variant. There have been 5 variants identified by the World Health Organization, and the ones that have been important in the United States were Delta and most recently Omicron, which was stunningly infectious, but fortunately not as lethal in terms of the percent of people who were infected who succumbed to COVID. But still, in this state, since December 1st, we've lost 10,000 people, presumably most of them to Omicron. Now, the Omicron sort of spike, wave, whatever we want to call it, it was really like a cliff. This was the Omicron sign of the vertical rise in case counts, is clearly coming to an end. We have seen a real decline in the number of cases. It really went up and now it's coming down. We expect that the tail will be longer than the surge, but it's clear that the Omicron surge is coming to an end, and with it have come many of the requirements have been lifted. Throughout the COVID pandemic, we've seen an unequal impact across communities. In particular, communities of color have borne the brunt of excess mortality due to COVID, with rates still double that of the nation. But in the early days, we were seeing 3-4-fold higher mortality rates among African Americans and later Latinos as compared to whites. I think many of us saw Omicron as sort of such a wildfire of infection. We were up to over 90,000 cases a day in New York State being diagnosed, that some may have lost track of the fact that we were continuing to see these disparities in impact. So not only during Delta, but also during Omicron. Here, you can see it here. This is African Americans, and the hospitalization rate went up to 2-fold that as compared to whites. That's the line here is white is whites. We still don't fully understand why the impact was particularly on African Americans. And I'll come back. New York City has done a lot of delving into this, and I'll come back later to talking about some of the reasons that we think this pattern was seen. But here you can see as it surged, the gap widened, and it went up to a 2-fold higher risk of hospitalizations. But here we are now with the Omicron surge coming down, as you've seen here in the red, cotemporous with the rise in case counts that was coming, and hospitalization is a lagging indicator. First you get people infected, then some of them will get sick enough to need to be hospitalized, and then of those, among those who are very sick, we will see some deaths. This line here is a little bit subtle, but it's an important point. We know that vaccination particularly protects against serious disease, the type of disease that can land you up in a hospital. And as the hospitalizations rose during the Omicron surge, we saw a real uptick. This is the rate of vaccination. So not the proportion of people who are vaccinated, but the rate at which people were seeking vaccination. And it really went up as people became concerned about the Omicron surge. But you can see what's happening now. That the rate of vaccination has been steadily declining, and it has sort of pretty much stalled. This is not good. because vaccination remains one of our key tools in preventing serious illness in particular. And we are doing well compared to the nation, but we are not doing as well as we could do or should do for this highly contagious variant. So on this graph, you'll see the breakdown of vaccination by population age groups. And you'll see that we're doing really well among people who are older. Over the age of 65, we're seeing virtual universal primary course. That means the 2 doses for most people. Immunocompromised people will get 3 doses. But here you'll see that in children, who became eligible for vaccination the last in this group, the 5 to 11-year-olds, we're still just over a third. That means 2/3 of children who are eligible in this age group haven't been vaccinated. Now, it's important that they be vaccinated for a couple of reasons. One is that they protect themselves, but also, even as we have not seen the full protection that we saw against the initial variant, it does offer protection. So it also reduces community transmission when you have children vaccinated. Now, we are recommending boosters for everyone who is 12 and older. They were recommended first for older adults and all old adults, and for 15, 16, and 17-year-olds, and now for all people who are 12 and over. And you can see in this graph, where we start with 16 and 17-year-olds, that the younger groups have the lowest booster rates. But still, not to get too wonky here, if you multiply out, even in the older group, who have 2/3 of our deaths have been in people over 65, if you multiply out 95 times 70, which will give you the percent, which will give you the percent of people who've gotten all of the recommended shots, the primary course and the boost, we're still in the 60%, and that's not high enough. We really need to get the booster rates up for everybody who's boosted, who's eligible rather, and as well as get everybody who is eligible to be vaccinated. This remains a key protection against serious disease, which we didn't have when the variant arrived. And it's important for children because during Omicron, we saw more of children affected than we did during the first surge. We have, as a nation, we estimate that about 1/3 of children, that's children under the age of 18, who've died during the pandemic, died during the Omicron surge. And in New York State, our numbers are about that. We had 17 children die since the beginning of this year. So that's what's that, January, February, March, and we've had 41 children died in the preceding 17 months. So Omicron had a higher toll, was more likely to have a child hospitalized. And this graph shows the proportion of deaths in young people who are not supposed to die, really changed with the surge. And so this is an important point to keep hammering home. Although the risk in children is low, these are children who we owe the highest responsibility for protection. And we do see children dying in New York State. About 29% of the deaths in children under 18 due to COVID have been related to the Omicron surge. So now I'm going to take a moment and talk about what we're all hearing about, which is the fact that we are seeing a rise in cases around the world. we're probably looking most closely at the United Kingdom and Europe because Asia, the situation in Asia, particularly in China and Hong Kong, is different than in the United States. As you know, China has pursued a zero case policy using quite draconian methods of shutdown to try and close down any outbreaks. And in Hong Kong in particular, where they're seeing a really serious surge at the moment, their elders were not vaccinated. I've just shown you data showing that older people had to have the highest vaccination coverage here in the United States and also in Europe. So we've been looking at Europe, particularly the UK, which historically what happened in the UK would be followed, it would reach New York in a couple of weeks. And here you can see that they are experiencing a rise. And that rise is due to this very crafty virus, which continues to mutate. I mentioned that we've had 5 major variants, 2 of which have had big impact in the United States. Aside from the original strain, there was the Delta variant and then the Omicron variant. But the Omicron variant itself is changing. The initial variant shown in this, I don't know what to call this, a darker but not darkest blue, was here. And then we started seeing a different version of the original variant. This is the original one is BA1. This one was 1.1, and you can see the dark blues started crowding out the original variant. And here comes the one that everybody's talking about, the BA2 variant. And you can see that it is crowding out the other variants. And in Asia and in the United Kingdom, it now is clearly the dominant variant. We haven't seen the kind of astronomical rise in BA2 that's been documented in Europe and the United Kingdom. You can see it's going up. The last number I had before this 42% was 39%. So it went from 39% to 42%. So it's going up, but it's not. We're watching it, but we haven't seen the huge escalation and rapid increase that was seen in the UK. We have some other tools in addition to tools to protect people. We have some emerging tools on how to keep track of the virus. And this is a really useful strategy, which is still being brought on board. This is a graph of wastewater surveillance in the United States. This is us. You can see that most of the wastewater surveillance that's going on in the country is in the Midwest and on the East Coast. But we in New York are, part of this early adopters of wastewater surveillance. And the thing that's good about this, something like 85% of people are on sewage. I know it's in the morning, but so I'll use the word wastewater mainly. And this covers 75% of the population. So we get a passive window into what's going on in terms of shedding viruses without having people having to do anything. And we have been tracking that. This is what wastewater look like. I guess these data, they go up every week. These data are from a week ago. They were just updated today. So I'm going to show you that. In general, you probably know that when we graph stuff, red is meaning something more serious is going on. So we are picking up more of the variant, BA2 variant in wastewater across the state. We expected this. Because we have a more contagious variant, it's anywhere from 30 to 50% more contagious. We're relaxing our restrictions. People are mixing more. At the beginning, we talked about how everybody's kind of getting tired of all this. So that as long as we have COVID with us, this is going to be accompanied by more infection. And I'm looking forward to our ability to predict this with wastewater. I don't know how well you can read this. This is applying our data retrospectively to the Omicron surge. And you can see here was the first signal from wastewater, which was about a week before we saw cases begin to go up. So this will really be helpful to us as we go forward. We're seeing a slight, modest increase in cases, but as you saw on an earlier slide, I feel like I have to take you back to that slide. Where is it? Oh dear, way back. Here, as you could see in this earlier slide, when we're talking about upticks, and this is central New York here, we're talking against a base that is far lower than it has been in months. We're down to levels that we last saw in July and August of last year. So I hope I won't make everybody dizzy as I go forward again to catch up to where I should be in my remarks. So I think in the last couple of minutes, I'm going to talk a little bit about what we've learned. We've learned a lot about how how things that existed way before Omicron regarding the impact of racism in our society, which is often anti-Black racism, but extends to all people of color, had an impact on the inequities that we saw in hospitalization rates. And this was related to numbers of things. And this reflects the thinking of our colleagues in the New York City Health Department. People who are low-wage workers were more likely to have jobs that meant they had to leave the home and couldn't work remotely, as I was able to do during the whole of COVID. There also have been concerns about vaccination that led to delays in vaccination and concerns about seeking healthcare for numbers of reasons that meant that people were more likely to be diagnosed later in their disease. The data also show that the therapeutics, which we want people to understand, are now available to them. I think that probably there's not enough understanding that people with mild or moderate symptoms who test positive ought to call their healthcare provider right away and have a conversation about whether they should get either monoclonals or antivirals. But we know that the uptake among Black New Yorkers of treatment has been lower. And of course, we know we can't completely unpack that the data that I showed you on the twofold increase in hospitalization, because we don't have a lot of details about what was making people sick, whether they had other underlying conditions, which are also stratified by race in our society, that made them more likely to have a bad outcome. So, we have a real challenge to address underlying factors that drove the contours of our epidemic. We know that this, is linked to our history as a nation. And I'm hopeful that one of the outcomes of COVID is that we're prepared to talk about it more forthrightly, to use words like racism and to talk about the ways in which that has modified the impact of the epidemic. We're shifting increasingly to talking about ways individuals seeking and using the tools that are available to them to protect themselves. And there's a real chance that this will be stratified by people's resources, which in our society are deeply stratified by not only by education and income, but by race, ethnicity. As we make this shift, away from statewide requirements. I want to make clear that as a state government, we continue to adhere to what we view as truly core responsibilities. We need to keep track of things and be able to tell people where we stand with the pandemic using novel strategies like wastewater surveillance. We have an obligation to make sure that if we want people to be tested, that they have access to testing. Increasingly, that's not only testing sites, which remain open, but also home test kits. And if we want people to get vaccinated, we need them to have access to vaccination and, continue to provide information on therapeutics. But of course, much of this will lie now with individuals. We want people to make a decision based on their own risks. I often refer, and I have her permission, to my mother, who is 94 years old. She is at very high risk if she gets infected. I take great care because I see her regularly, and I consider her risk when I consider my behavior. So I wear masks in crowded indoor spaces and so on. We, of course, do still have some of these tools, these mandates in place. We're continuing to require masking on public transportation and healthcare settings and nursing homes. Businesses and other entities can continue to require masking. I believe, I don't know if this has changed, that Broadway is still looking at masking for theater goers. And of course, everybody, including myself, should feel free to wear a mask in settings where they feel that would give them the protection that they want. We've really gone all out on making test kits available. We've distributed over 50 million tests. We're sending out additional kits to food banks and electeds and local communities at senior centers. We continue to broadcast to the treatment community that that they should prescribe, and we want to broadcast to the public that they should ask, have symptoms, get tested, talk to your healthcare provider. And of course, I've talked a lot about the need for vaccination. We have a lot of work ahead of us. We have a really good budget this year with resources allocated to help rebuild our health system. We also have a big problem with trust. I'm really pleased to see these data that show that people trust their nurses most of all. But unfortunately, governments, the trust in government and health departments, here's the state health department, 41% of people are not what they should be. And so we have our work cut out for us to regain the public's trust. And I hope that by, sharing what we know, being clear about what we don't know, that we will be on the path to doing that. So with that, I'll thank you, and I'll stop sharing my screen and see if we have a few moments for questions and answers.
Oh, Commissioner,
well, I hope your questions, and I hope I can answer.
Thank you. We've got a bunch already. So I guess but the numbers that you showed us in terms of vaccinations in particular, are there still disparities throughout the state? Is downstate in New York City much more vaccinated?
Yes,
upstate?
It is.
And
yeah, particularly in North Country, Southern Tier, and parts of Central New York, in general, we have lower vaccination rates upstate than downstate. And yeah, the ratio, I think we've done a really good job with what received a lot of attention early in the pandemic about about skepticism of vaccination among African Americans. And we've done a really good job, although among young African American men, we still have lower vaccination rates than I'd like. But the bigger divides are more, frankly, along what I would broadly describe as political lines. Unfortunately, although a virus obviously doesn't care how you vote, the attitudes towards vaccination have really been colored by partisan politics.
Have you get around that in terms of overcoming that as you've done your work so far?
Well, I think people respond to mandates. They did respond to mandates, and we really boosted our vaccination rates with the mandates. And the other is the people respond to surges. You saw that there was a real uptick in the rate at which people were going out to get vaccinated as Omicron arrived in the state. People went out and got vaccinated. And, I think that as the transmission declines, which it has declined, it's been a remarkable, up and down, that people's, sort of interest and concern about getting vaccinated has dissipated. But this is really a tool that we have that will protect people clearly against serious illness. And so I think what will work is just keeping at it. And the numbers keep edging up. Our nursing homes, we're doing well. We have 70% of nursing home residents boosted. And 90% are fully vaccinated. But as I told you, 9 times 7 is 63% of residents have gotten the full benefit of all of the recommended shots. So, but still, 70% boosted is good. And so we just, we just keep at it.
You talked about your being careful because your mother is potentially in a vulnerable community. Do you look at kids below the age of 5 as also in a vulnerable community at this point who are not vaccinated?
Well, as everybody knows, the risk of serious illness and death is low in kids. But I personally feel that every society, seeks to protect maximally its children. And so I understood why New York City made the decision to maintain masks for under 5s for a bit longer. And this is completely consistent with what the state has indicated, that everyone can look at their, local jurisdictions can tailor their recommendations to their setting. Now, of course, that has now been, it's been announced that it'll be lifted. I'm not sure that it's happened yet. But what we want for our kids is zero risk. Well, we can never provide them with that. There is no zero risk for virtually anything, but we can protect them and protect the under 5s who are not vaccine eligible by trying to make sure that everyone around them is vaccinated, and sort of think of it as a wall of protection around the littlest kids.
And does the Moderna data that they disclosed, I guess it was yesterday, does that give you, did that data seem reasonable to you that it would reach approval and that would be beneficial? Or
well, I don't know. I mean, we've so far we have never gone out ahead of the FDA and the CDC. So I think boosters, additional boosters are coming. Vaccinations for the small kids are coming. I do want to point out that that the best protection for very young kids under 6 months, is a vaccinated mother. And I think many people worry when they're pregnant that I shouldn't have anything medical touching me, but it's a good idea and recommended if you're unvaccinated and you're pregnant that you get vaccinated. It's a way of protecting your child.
One byproduct of of the pandemic has been seeming to be an increase of the mental health challenges people are having. Yeah. Can you talk a bit about how you approach that? And I assume that will be with us for some time. Ask how you prioritize.
That's a really good point. And I mean, I think all of us, this has been a really difficult time for everybody. But children have, been displaying really worrying signs with data showing an increase in anxiety and depression, an increase even in suicide attempts. So at the state level, the Office of Mental Health is separate from the health department. It's led by Ann Sullivan, who I had the pleasure of working with when I was the city health commissioner. She came from, and so she's been working on numbers of programs. I think the place to work on this is in schools. We clearly have learned that going forward, a key place to keep as safe as we can is our schools, so that we can keep kids in schools. And that I've heard former Health Commissioner Dave Chakshi talk about, how he would say he regrets that the schools were closed sort of precipitously when they hit a magic number, 3%. It was really important for us to have kids back in school. It's good for their socialization, their mental health, and of course their learning. So anyway, I think that the place to focus our mental health efforts really are in schools and in pediatricians' offices. So that's the kind of work that we're talking about. Another long-term effect is long COVID. And I would be remiss if I didn't mention that. We understand very little about it. There are a number of hypotheses about it, but that's why it's always better not to get COVID, because we don't know why some people, apparently healthy, athletic, fit people, have gone on to have long COVID. And that will be with us for a while. And there's no reason not to think that Omicron, which infected very many people, might not also be associated with long COVID. So we have the mental health impact of the pandemic. We have the potentially long COVID. And of course, we have all of the economic and social disruptions that occurred. So even as it trails off, it's not over.
And then kind of talking about the surge in Omicron, there was a narrative out there in the last few months that like hundreds of thousands to millions of people were walking around with asymptomatic COVID and no idea that they have it. Do you have the feeling, one, that much more of us had it than realized, and you get the feeling with BA2 that
may be helping us now, that we have a higher, clearly we have higher population immunity than Asia and China, particularly where they had the zero transmission strategy that meant that they didn't have people acquiring immunity from natural infection. And that's one of the beauties of wastewater surveillance, is that it doesn't require people to seek testing to identify it. We don't really know what proportion of people had asymptomatic infection. We haven't really done any, population surveys. A lot of the focus has been on people who have come forth, but there's no doubt that that Omicron had a much higher proportion of people who were infected with mild or no symptoms. All of us have heard of people, right, who in our own personal lives who, got tested and found out they were infected and didn't really have much in the way of symptoms. So it may be that that's part of what's molding what so far seems to be a growth in cases, which, but not this type of growth. But we're keeping an eye on it. In central New York, which is where Syracuse is located, we're definitely seeing more cases now. And so, I think the word is vigilance, but we know that we have all these tools now that we didn't have before, both in terms of surveillance, protection, and treatment. So, we're beginning to view this as something that we're going to have to live with, and the word eliminate or eradicate, you won't hear coming much from people in public health.
That leads to two important questions. You use the words vigilance. So vigilance means something for you as the commissioner responsible for the whole state. What does vigilance mean for the people on this Zoom who maybe are obviously themselves, their families, and their coworkers and loved ones?
Well, it means to me that each of you should think of, first of all, are there people around you who aren't vaccinated, who could be vaccinated, who aren't boosted and could be boosted, or does that include some of you? And, this is time to think again about whether or not you want to proceed to get all of the recommended shots. And then, we have all these test kits. If you have flu-like symptoms, and so that means fever, runny nose, cough, and even diarrhea. I have friends who that was their first symptom of COVID. Test yourself and find out. If you test positive, call your healthcare provider and have a conversation about whether you should have treatment. And of course, I mentioned that I continue to use my masks. Of course, I wear them on public transport where they're still required. But I also, when I'm in crowded indoor spaces, because I have a potentially very vulnerable family member, and we may not always know whether we're infected or not, right? So I consider that when I in determining my own behavior. So that's the best advice that I can give right now. That as ever, it's always useful to think about the most vulnerable person in your circle and what kind of protection you would like them to have.
So initial, let's say, information about masking was you mask to protect the person you're next to.
Yes.
Has that changed? Are you now with a better mask? Are you really protecting yourself?
Yes. Yes. We're using high quality masks. I always have one nearby. I mean,
those are material. This
is not an N95. But it's a well-fitting mask. And when I go on a Amtrak, which I do quite a bit, I wear a higher quality mask. I wear an N95, and they protect me. But they also protect others. And I think that's a nice way. I ran into a young woman at one of the convenience shops in the Albany train station. She said, I get vaccinated to protect myself, and I wear my mask to protect all of us. So, we no longer have them required. And I know all of us are sick of seeing people covered up and so on, but I hope that when you see somebody wearing a mask, you feel like that's okay. That's what they decided to do for them.
You said we're not using the word eliminate anymore. But what does that look like in the future? Is it we're reacting to surges? Is it this constant reference to it's like the flu? I guess I would say is, do you think the fear factor changes for people in terms of how they interact with the universe because public health outcomes change, or does it sort of feel like it does now for a long time?
Well, I think, we've had a whole series of prominent people announce that they tested positive recently. I think the most recent one I heard of was Hillary Clinton. And often there'll be an additional refrain, I'm fully vaccinated and boosted, so I'm not very worried. So I think that, that there'll increasingly be a willingness to accept, have an illness what we should really not accept is preventable mortality. We should never accept it from any cause. And so I think that that will be the key reason for us to be vigilant about vaccination as protection against severe illness. Now, I haven't talked at all about the globe. And we have a big problem with vaccine access around the world. And as long as we have hotspots, we have surges anywhere in the world, I think if anything has taught us that we're all connected, it should be this pandemic. So the Alpha, the first variant, arose in the UK. The Delta, I believe, arose in, gosh, I get them mixed up. One was in Brazil, one was in the UK, one was in Brazil, one was in Omicron was, we think, in Southern Africa, one was in Asia. And of course, the original strain was in Asia. I think it's Delta, we think came in from India. So, these, nobody has been able to protect themselves from the global spread of this variant. And so as long as we have hotspots around the world, we're going to continue to see, the virus adapt to people and to modify itself. Fortunately, Omicron modified itself in ways which were highly contagious, but not highly lethal. So, we also have to think about how we're protecting the whole world and not just our own country.
And what would that require?
Well, that's making vaccine more available all around the world and making treatment available. And it's beginning to happen. I think we could all debate whether it should have happened much more quickly.
I want to talk a bit about, ask you a couple of questions. You talk about the inequities and how COVID has disproportionately affected certain communities, particularly the Black community, African American community.
Latinx and Indigenous also. Terrible devastation in Navajo Nation in wave 1, for example. Yeah.
The list of things that impact that was deep and substantial,
right,
and hard to tackle, I would say, or there's just a lot. And so what I would say is, if you had to start somewhere down that list of huge priorities to change that, what do you see as the most impactful or the right few things to start on? And then the logical question for us as ABNY is, how can we help? But let's start on where do you start?
Yeah. I think in public health, increasingly, you'll just hear people talking about vaccinations and treatment because that's in our lane. And there, we're very serious about delivering those to everybody who's eligible. But I think we also in public health have to talk about the importance of reducing exposure. And it's clear that at least in wave 1, that people who are classed as essential workers were far more likely to be exposed to the virus. So if, obviously, first you have to be exposed, then you get infected, and then the outcome of your disease may also be modified by what kind of condition you're in at the time you get infected. So I think that the work that we've done in public health and ensuring, for example, that the mistake of not adequately protecting nursing home workers, home health aides, won't happen again, that there are now in New York State requirements that nursing homes have adequate stocks of personal protective equipment, and that we have required that healthcare workers be fully vaccinated, and that's for the protection of themselves, but also for the protection of the people who they care for. So these are all actions that had to do with reducing exposure, and we shouldn't forget about them. They're still all in place, but when we talk about vigilance, we're talking about vigilance in terms of making sure that these resources remain in place. But most of my time is spent talking about how we need to get the vaccination rates up. And get at this moment, a lot of that conversation is aimed at adults is about getting boosters. The question about the impact of racism in our society is one that really is our obligation, not just as professionals, but as citizens or residents of this country. And I agree with you. This is centuries in the making, and there's no magic bullet. But a good first step is the beginnings of a conversation. And that none of this is natural. There's no reason that a person of African descent should have had a multifold higher risk of death than a person who's classified as white. There's no biological reason for that, and we should not accept it. We should say, what do we do? And that is lots of things. It's supporting public education, high quality public education. It's speaking out against discrimination in the workplace. It's all of it.
Thank you. Question I have from one of our people on the Zoom. What are there any special efforts being made for vaccinations and boosting for pregnant, postpartum, and breastfeeding women, and especially women of color at this time?
Well, we're working really hard to make sure that there's that everyone has the opportunity for vaccination, and including working with kind of less traditional partners like churches, for example, and community-based organizations to sponsor vaccination sites. I think you ask a good question about pregnant women and women who are breastfeeding, and I actually don't know the answer to that one. Whether we have any special efforts. We certainly have been, trying to get out the information that it's that there's no danger to your developing a baby of getting vaccinated, and no danger while you're. Anyway, you make a good point. We should think about that. I think that a lot of people are not clear about that. I often, I try to tell personal stories because, for all of us, this affects not just us as public health practitioners, but as people. And when my daughter was pregnant, she called me, asked, should I get vaccinated? And I said, yes, absolutely. And she let me tweet it out, 28 weeks pregnant and vaccinated.
She has a trusted person to call in her life. So I think that's something a lot of us need. Look, it is very personal to all of us. I in the last week, I have 3 little girls, they're 3, 6, and 9. My 9-year-old has gotten 5 emails in 10 days saying you have been exposed at school.
Oh boy.
And we never got those. By the way, she already had COVID, and she never got those emails before. And, I think that we all look at this with some degree of fear. I'm going to take that to just a final question or two. When you showed the map of the wastewater downstate where we are, you have the little red circles, and then I saw it said hot spots. So we are in hot spots. And so first,
well, that's wastewater. I don't know. It's there.
What is it? So we watch that, and then you watch the 3 things: positive tests, and you watch hospitalizations.
Right.
What's the? I guess this is a bit of a question about the future. Is it you turn the dial on restrictions? Are there triggers you're looking for that you're seeing, or you're really kind of seeing that it's not, other than wastewater, you're not seeing much else at the moment?
Well, in Central New York, we're seeing an increase in case rates. That's it now. I mean, everywhere it's going up, by the way. It's ticking up. I don't know if I won't bring the slide back up, but a 30% increase, maybe from 8 cases per 100,000 to 11. These are low numbers. At one point during the Omicron surge, we had 400 cases per 100,000 per day. So, this isn't a different league. So we're talking about that tail, that low tail, and bumping up from that. And the proportional increases when you have small numbers, right? When you go from 1 to 2, that's a 50% increase. So the percent increases seem really big, but then the actual numbers remain small. But in Central New York, we are seeing what looks like a disproportionate increase, still low, but higher than it is in the rest of the state.
But you don't see an inevitability that, like, in terms of as numbers climb, they inevitably.
No, but we have the tools. I won't hesitate to recommend to use them. At this moment, I don't see it, although I'm concerned, as you've gathered, about Central New York. But we're seeing upticks everywhere, but my small ones, and we have a more contagious variant. We have relaxed restrictions. We have a public that's tired of, not going anywhere. So all of these together, more mixing of people, fewer, using methods like distancing, masking, and a more contagious variant it's inevitable that we're going to see some increase in transmission. But people seem to be prepared for that. What we don't want is a surge, and that, that's what we're watching for.
So, Doctor, thank you. It gives us great assurance that you are there, watching out over all of us at this incredibly complicated time. I do have one last question, a little off topic, and you can feel free to decline. Chocolate milk. Chocolate milk. Bad for kids. Because I will say, by the way, I'm going to say I'm of the school. Like, if
I didn't give my kids chocolate milk. It's good for kids to drink milk, but our kids aren't going to get rickets. We're not in a ricket era. And I know that there have been concerns that kids who are deprived of chocolate milk don't drink milk. So we're having those conversations. The previous health commissioner was in favor of chocolate milk. In New York City, we worked hard to work with the schools actually to reduce to change milk to 1% milk, and to limit flavored milks. So we're having discussions.
Okay, couldn't resist. Anyway, Doctor, on a serious note, really, thank you so much.
My pleasure.
And look forward to continuing to hear from you.
Thanks very much. Appreciated your questions. They were good questions. Hard questions, some of them.
Thank you.
Not the chocolate milk question, but we will get back to you on that. Okay. Thanks very much.